Thanks a lot, Julie. It's a pleasure to be with you all tonight to talk about a topic that is very near and dear to my heart, because we all hate complications, and unfortunately, hurting people with our opioid prescription patterns has become a big complication, albeit one that we don't see frequently because it's not something that shows up in our clinic every day. I've been working on this topic for about 5 years, and this is a culmination of all of the work that we've done, the research, quality improvement, and I'm happy to address questions at several points during the talk. You can also write questions in the chat box, and we'll look at it and address any points that people have throughout the meeting. I have nothing to disclose. I have no financial disclosures, and I will be discussing an off-label use of dexmedetomidine, or Precedex, which is an alpha-2 agonist. I'd like to first acknowledge all of my partners, our mid-levels, our students, our nurses, and people who have supported me in doing this work. And all of the wonderful residents and fellows and medical students who have done a lot of the diligent chart reviews, posters, presentations, and have also become very engaged in the process. Our big picture. Back in my time in training, where you can see by the red arrow at the bottom from 1991 to 2001, the biggest problem of an unintentional drug overdose was crack cocaine. While I was ending my training, we had a lot of drug reps come to the office to say, hey, you should really use these wonderful, amazing new opioid prescriptions because you'll never get tolerance, you'll never get addiction, they're great for pain, and then you start to see what's going on. This is a figure from the Ohio Prescription Drug Force, and it's mirrored across the country. I believe they did similar studies in Pennsylvania and in Utah, and we see that at that time, 1999, 1977, the number of unintentional drug overdoses from prescription drugs started to skyrocket. And why is this? We'll get into that in a second, but now we have something very disturbing in that the number of deaths from unintentional drug poisoning has overtaken the number of deaths per year by suicide and by motor vehicle accidents. Why did this happen? Way back in 1997-98, the Joint Commission came out with pain, the fifth vital sign. And this, for those of you who might not remember or have been aware of it during this time, was because cancer patients, mainly in California, were being undertreated for pain. And very well-meaning people said, oh my gosh, this is awful. We have to treat pain as the fifth vital sign. We have to record it, and we have to treat it appropriately. And unfortunately, as with so many other things we do in medicine, we overdo. And this data became extrapolated from pain to treat cancer to pain to treat everything. And narcotics became used for many conditions. And there became direct consumer-to-marketing campaigns to try to get people to ask for it by name. Unfortunately, this also led to diversion to family, friends, people who are wandering through your house, and improper disposal, because we're giving people all of these amazing medications and we don't give them any way to get rid of them. And so it's just compounding the problem. And I think psychologically we have all come into these issues. If a little thing is good, a lot's better. And I see it as a similarity to some of the escalating antibiotic resistance problems, which really started back when I was in college. I remember doing a presentation on drug resistance in 1985. And it's like only recently that people are going, oh my goodness, that's a really bad thing to happen. And so we did this, we overdue, and now we're facing the problems. And thankfully, the Joint Commission has recognized that our current approach to pain, primarily opioid use, has not been very effective. And so now even they are advocating multimodal pain management strategies. And one can definitely state that management of expectations needs to be done in everybody's practice. So this is our personal history in my practice. We were sitting in the office one day, and one of the PAs was refilling a prescription for one of my patients and talking with him on the phone, and I felt that the refill was completely inappropriate. And he and the nurses kind of said, but you guys all do things so differently. How are we supposed to know what the right thing is to do? And we know that unnecessary variation in care leads to increased cost and complications, but I didn't realize that we were all so very different. All of my partners are board certified, they're well trained, and I decided to look into it to see, are we really all that different? And so one of my fellows did an initial study. We looked at opioid prescription patterns among 5 plastic surgeons for non-workers' compensation carpal tunnel release. We picked 30 people per surgeon, and we looked at the average number of pills that we prescribe for carpal tunnel. And the range was from 0 to 40. And of those people, of the 30, 11 to 18 patients in each surgeon group were prescribed no opioids whatsoever. And so this wide variation within and between surgeons suggested that we had no good rationale for prescription size. We're sitting there going kind of, well, you seem like a 0 kind of person, or you seem kind of 40. And we had no good reason to say why one person seemed like they would need a ton of opioids for a very small procedure and why other people would need absolutely nothing, other than, these, quote, gut, I know my patient sort of things. So what are the problems? We're randomly prescribing opioids. And so that's a problem of physicians. And how do we get physicians to change prescription patterns? If any of you have done quality improvement, you know that getting a physician to change any behavior is really, really challenging. And we had no idea how well we were controlling the pain. So what constitutes an ideal prescription size? In my case, it's for hand surgery. And what are the better ways to control perioperative pain if we're not going to be looking just at opioids? So our big challenge is we are a big part of the problem, and we don't recognize it, so we won't change our behaviors because of many reasons. There's inertia, the belief that we have no need for change because our practices are safe and effective. As I mentioned earlier on, we don't know if people are having problems with opioids. We know if they are unhappy and they say that they want more of them, but we don't know that any of these prescriptions that we're putting out there are leading to overdose or death in either our patients, their family members, or their friends who may be picking them up from medicine cabinets. And if you think that doesn't happen, I'm afraid you're living in a little bit of a dream world, because one of my colleagues who's just finished being our chief of staff, he and his statistician wife had opioids stolen from their medicine cabinet at home during a family Christmas party. And so it's happening to him, it's happening to many, many people. So we need to become more aware of these risks and be willing to change our behavior. There's also the fear of change and of litigation, and patients won't like me, and my satisfaction scores will go down. And I would say that, becoming a drug pimp for people is not really an appropriate way to use our training or the responsibility that we have to be able to write for opioids. We also have the problem that there's no awareness. We don't have awareness of current norms, and we really don't have any existing norms for what are appropriate prescription sizes for various conditions. And I have heard almost every argument you possibly can about this plan over the time. They'll call in for more drugs if we give them a small initial prescription. They'll go somewhere else, and for that one, I say yes, fine, that's okay. We do have a state ability to see where people are, a website that allows us to see where people are getting their drugs, and we can ask them about this. But I've had several patients say, "Oh, you're one of those kind of doctors." And my response has been, yes, tell your friends, because I'm not interested in being their drug prescriber. The concern about bad satisfaction scores or declining satisfaction scores I'll address later, but there is no evidence that this happens. There's a concern that talking about this takes too much time, and once you learn it, it really doesn't take much more time at all. And the concern that nothing's bad is going to happen if we continue doing what we're doing, and I would argue that that's not true either, since we're killing over 16,000 people a year in the U.S. from prescription drugs. So the first step that we did was to do chart reviews of prescription patterns, so initials and refills for common hand conditions. I used trigger fingers, metacarpal fractures, de Quervain's releases, and wrist ganglion cysts. And from this data, I chose a goal initial prescription size based on whatever distribution seemed reasonable and seemed something that I could get my partners to agree on. There were some dosing ranges that seemed to be appropriate for a mean, others a median, and others a mode. And, this is not anything that is, written in stone. It's just if you look at a bunch of people's prescription patterns, what seems to be a reasonable pattern if you get rid of some of the outliers. I then got agreement among my partners that they would comply with the new drug recommendations and created a laminated bright pink card. This was recently published in the Journal of Hand Surgery and, shows some things that are on the pink card. I also have included a copy of the pink card as well as a copy of our pain contract for anybody to use. And then I talked with this about this with our trainees, our mid-levels, our nursing staff in clinic. I had to talk to the PACU nurses because they thought I was just being horrible. And then created systemic assists. We have Epic as our electronic health record, and we created reminders to help people do the right thing and the easy thing. And we included a pain policy in our preoperative visit material. And I'll go into the preoperative pain policy in just a moment. And then we did periodic chart reviews to see if what we were doing had any effect on prescription practices. So the pink card, an educational assist device that's laminated, bright pink, 3 by 5 inch. And my premise was that smaller surgical procedures should be treated with fewer opioids, and bigger surgical procedures probably need a few more opioids. Everybody is different. All of our patients are different, but generally this strategy has been successful. I also add additional strategies such as pre-incisional local blocks, because there's good anesthesia literature to show that when people are under even general anesthesia, they know when they are being attacked by a knife. Their blood pressure, their heart rate all go up. And so every time that I do anesthesia, I give the local block before we do the prep so that it has a time to kick in, and I use a short and long-acting lido and bupivacaine with epi for most cases. We also use vitamin C for distal radius fractures and all large crush injuries. This is supported by level 1 data, and it was supported by the American Academy of Orthopedic Surgeons in their distal radius fracture guideline. We figured that a large crush injury was similar enough to a distal radius fracture, and so we use it for those as well. It's cheap and it's easy. And then we routinely use NSAIDs for all people who can tolerate them for 3 days postoperatively. There's a lot of anxiety in the orthopedic literature about using ibuprofen after a fracture, but even the American Academy of Orthopedic Surgeons are currently online with saying that, especially for upper extremity fractures, using a few days of NSAIDs is not going to inhibit bone healing. We also acutely use gabapentin and or dexmedetomidine, and considering a clonidine patch, 100 micrograms that you put on during surgery and leave on for a week. So there are a bunch of different strategies that we can do, and I'll also mention those later on. This is a picture of a little packet that's in our resident medical student area, and every new resident on service is oriented to the pink card and asked to take one. I've taken these to various meetings, and they go away like candy. It's wonderful. So I'm hoping that people are adopting this. On page 1 of the pink card, I have recently changed it so you have the newer version online, and this is the older one. So what says intraoperative nerve block is now a pre-incisional nerve block. You can always add a little bit more at the end if you like to. Considering Precedex, if you're repairing a nerve, using a half a mic per kilo IV over 20 minutes at the start of the procedure. This is a moderate dose. I've done a quality improvement study recently on about 350 patients that I've used Precedex for, and I haven't had any issues with respiratory or cardiac problems at this dose over this shorter period of time. We use ibuprofen, Tylenol, ice to the armpit, elevation, and then on the back page are the opioid guidelines. For small things like little Mohs surgery, triggers, now we're using carpal tunnel, non-op Dupuytren's, Xiaflex injections, small lumps and bumps, get no opioids. And we've started bringing the carpal tunnel mostly down into the no opioid category as well, because most of our carpal tunnels are being done in the office under straight local anesthetic, and people can see that it's a relatively small operation. In the 5 to 10 group are small joints such as mucus cysts, de Quervain's, operative Dupuytren's, non-operative fractures, and small joint fusions. Then you have mid-range, 20, and for large risk trauma, 40. And so I've asked the residents also to consider using the acute gabapentin and then the vitamin C. All right. In our electronic health record, I'm sorry, I'm having an issue here with my computer. All right. On the electronic health record, we changed opioid defaults from 1 to 2 tablets POQ 4 to 6 hours, which people then interpreted as 2 POQ 4 hours PRN to 1 POQ 6 hours PRN severe pain, because people generally tend to think that we're only giving them the medications that they need, and if you give them something that is having them take 2 opioids every 4 hours, they are going to take 2 opioids every 4 hours. And so you need to temper your expectation, or their expectations rather. We also added non-opioid options to the postoperative order sheet because people don't believe that ibuprofen is a real medication unless it's prescribed. So we put it to be taken on a scheduled basis for 3 days. And then we added a no additional narcotics as an alternative checkbox because the PACU nurses were calling us fairly frequently to say you didn't write out for any medications. And by checking no additional narcs and having a talk with them in the pre-op or post-op area, we did get them to stop calling us about the opioids. So it's just a change in expectations for the nursing staff as well. We've given a pain policy to all patients undergoing elective surgery in our department since 2004. I started this when I was on faculty at Ohio State, somewhere between 2000 and 2004, because I was tired of getting these calls in the middle of the night about patients I didn't know, and saying that they needed more pain medication. We're slightly changed now because you have to actually give them a script rather than phoning in prescriptions, but that was the main purpose. I was tired of people who were gaming the system and trying to get me to phone in prescriptions, and I wanted them to have a more rational expectation. So I created this pain policy, and then when I moved to Minnesota, I took it here, and we've been using it for the past 11 years. This has the stipulations that we will not fill prescriptions on the night or the weekend, and we will not do it on Friday afternoon, so you better call in on Friday morning. Our answering service will not call us about this issue. And so if you're saying I'm going to be called all the time, you talk to your answering service and say these are things that we will not do, so please don't even bother calling us. And that has been successful, so it's something that certainly can be adopted by other people. You have an a priori discussion of your opioid prescriptions. And on the pain policy, it says that we treat the pain appropriate to the type of procedure that you have. And, these are discussions that you need to have. And then we also mention the various risks, the need to manage pain in multiple ways. And I found it personally very helpful to say pain after surgery is largely related to, and I use the word swelling rather than inflammation because they don't understand inflammation. And the best ways to treat inflammation are ice, elevation, and ibuprofen, and rest. And so if you start setting these expectations, then your outcome will be better. And it's a much healthier discussion that you can have with people. So these are some key things about our pain policy. We don't prescribe pain medications in anticipation of surgery. We prescribe them based on the severity of your procedure, on the type of procedure, and we will not prescribe them nights, weekends, and on a walk-in basis. And so don't just wander into clinic hoping that you'll get somebody to write you out a prescription. We did a chart review 4 months after the start of the pink card, and I was really happy with this. We saw a 50% change in the number of prescriptions written, or in the size of the prescriptions written for ganglion cysts, 20% decrease for metacarpal fractures, 50% decrease for triggers, and 65% decrease for de Quervain veins. We had a number of people who had combination carpal tunnel and trigger fingers, and we had a decline of 23% for those people as well. And then at about the year mark, I did another search to see if the changes that we had imposed had actually stuck. Were people, and these are all physician behaviors, are the physicians still maintaining that practice of decreased numbers of pain pill prescription size? And we found out that it did. And if you look at the error bars, especially on 25,000, which is de Quervain veins, you notice that our standard error of the mean is really decreasing tremendously. And so we're not only prescribing fewer opioids, we're being more consistent in how we prescribe them. And that helps a lot when you're talking to people. And if you happen to see one of your other partner's patients, then you can say, this is how we manage pain here. And it can become a standard rather than a random exercise. These are our satisfaction scores, PICR, HCAHPS, whichever one. And they put a new survey in. It was modeled differently in the second quarter of 2012, which is why we had this huge dip. It wasn't a real dip because it bounced back up, but the confidence and the trust in prescriber, if you use this as a proxy, was unchanged around the time of the procedure or time of the study, which was between the two stars. And would you definitely recommend this group? Our scores did not change between the time of the study. And so we can see that the pendulum is swinging. I'm very happy about this. And we have a lot happier nurses because you don't have inconsistent behaviors on the part of practitioners. They can do something and say that, okay, this is how we all do it, and it makes everybody a lot happier. At this point, I'm happy to take some questions if we could unmute the group.
The conference has been unmuted.
Any questions from anybody? Okay, we can go on and make sure to write down.
The conference has been muted.
What? So key things, ongoing feedback to practitioners. In the publication that came out in Journal of Hand Surgery, one of my reviewers commented rightly so that one of the partners did not appear to have changed their behaviors tremendously with respect to their opioid prescription patterns, and that was true. One of my more senior partners is really not interested in changing. He said that he brought down the number of pills he was writing from 40 to 30 as a baseline. I can't do anything about that. All I can do is continue to provide encouragement and to show that, this is a standard, it's a baseline, and that, if you can cut them down by at least 5 another quarter, life would be good, but I can't force people to do anything. We had this paper come out in Journal of Hand Surgery, and 2 others are in progress. And I have been going around the Twin Cities to talk with other surgical groups to encourage them to try to do this similar thing. One of our residents presented some work that we have done on breast pain at one of the recent aesthetic conferences. And I've given this as a panel discussion at the American Association of Ortho as well as the American Society for Surgery of the Hand. And so I'm trying to get people to start thinking about this topic. So when we look at the problems that we had, the random prescription problem appears to be improving. The pink card does work to decrease variation in prescription size, and to get physicians to change prescription patterns, it takes numerous gentle reminders and creating systems that make the right choice the easy choice. So then the big thing, the next line of questioning that comes up is, well, how do you know that you're not leaving a bunch of people out there in horrible, debilitating pain? A great article came out from a group in Des Moines, Iowa, in, I think, Journal of Hand Surgery, also, I think, in 2012. And they looked at how many pills were left over after they prescribed them using their routine practice mechanism. And after a month, they had there were 5 surgeons in their group, and they all do upper extremity surgery. And after a month, they had several thousand pills that had been unused and were still floating around the city. And so I kind of guessed that we'd be seeing similar things. So we started doing a post-operative pain survey, and at the time of a poster that one of my residents recently put together, we had 156 hand surgery patients. 82 of them received an opioid prescription, but less than half of those pills were used. 20% of people who were given opioids didn't use them at all, and a few used just a few of them because they thought they should. Other methods of pain control were more effective. A large percentage used ice and elevation and rest, which was good. And fascinatingly, the preferred method of pain control, 55% of people who took opioids found other things more helpful. 37% of our patients indeed preferred the opioid, but 34% preferred ice, 35% preferred elevation, and 19% preferred rest. So you can take from this the fact that we are not leaving people in excruciating, horrible pain by using hopefully a more restricted set of opioid prescription patterns. So then now the next big job is to create perioperative pain order sets for all surgical teams, and this is work in progress across our hospital. We're trying to create sets that make it easy to prescribe preoperative gabapentin. And there's a wide range of doses that have been used and found effective. And this is primarily literature from the knee arthroplasty groups. And 900 milligrams immediately pre-op, or 1,200 milligrams the night before or the morning of, and then 600 milligrams TID for 3 days, or 900 milligrams the night before and the morning of. So almost any variation on a theme would work. I would probably tend to use a smaller dose if you're doing a fragile older person who's very drug naive. But a lot of these are people who have had chronic pain, and so maybe some of them have even been on gabapentin, and it's reasonable to give them a slightly higher dose. Other people use acetaminophen, 1,000 milligrams morning of. I practice part of each year in New Zealand, and everybody there gets paracetamol or acetaminophen, 800 milligrams of ibuprofen in the morning of, and some studies have suggested that minocycline, the antibiotic at the 100 milligrams the night before and the morning of, is successful in relieving chronic pain, and this may act to stabilize glial cell receptors in the brain. Intraoperatively, I'm not as familiar with ketamine, so I tend to use dexmedetomidine or a clonidine patch, and these can block alpha-2 receptors and can be very helpful for decreasing postoperative pain. The study that I did looking at safety of dexmedetomidine showed of about 350 people, only 5% of my patients developed a new postoperative pain syndrome that could be like a CRPS type of syndrome. And the literature suggests that a reasonable rate after surgery, or a not uncommon rate after surgery, is 9 to 16%. And so if that's the case, then I'm dropping it by, at the very least, half, which is encouraging. Postoperatively, we use vitamin C for about 8 weeks, acetaminophen, ibuprofen, gabapentin, etc. Usually the 3 days is the period of maximum inflammation, and so if you can control pain during that time, you can get them into a better phase. So in conclusion, I believe that it's really necessary to change our prescription behaviors, and that you can use simple and cheap measures to change behaviors without having a negative global impact on pain or satisfaction surveys. It's important to use multimodal strategies and to get everybody on board. And so talking to family medicine, it's important not to tell your patients to go back to their family doctor to fill their chronic pain medications. That makes the family doctors very unhappy. And I think that if you, document in your chart that I am done, the patient should not need more opioids now 2 weeks out after a distal radius fracture or whatever case you're doing, then family medicine, if you're in a multi-group study or multi-group practice, can look at it and say, nope, your surgeon said that this is it, so I'm not going to write you out for more opioids either. And it really helps us all to speak with a common voice, because minimizing the number of opioids that we prescribe is in our patients' and society's best interest. If you wanted to start with something very simple, start with the pain contract and discussion with your telephone answering service. That alone sets a guideline, it sets a standard for where you can go with this. And then, the next step would be to review some of the current prescription patterns for your common conditions. You have to educate your entire team, again, so that you can all speak with a common voice. And if you're trying to change other people's behaviors, using consistent reminders to try to ingrain behaviors is really important. And by doing this, I'm hoping that I can create a peer group and create a baseline so people can say, well, the folks in Minnesota are just using this number of pain pills for this condition, and so this should be reasonable for us too. So this is a copy of the pain medication policy and the pink card for your records. And thank you very much. I look forward to any questions that you may all have.
The conference has been unmuted.
If anyone has any questions for Dr. Kalliainen, please feel free to go ahead and state them.
This is Peggy Skiles. Loree, that was really very interesting. I know you mostly do hand surgery. Do you think this applies equally? I mean, I don't do any hand surgery. Does it apply equally to other surgeries? I know that I've started using, I'm blocking on its name, the long-acting local anesthetic. Yes. And that seems to be helping a lot in the immediate postoperative period. Exparel, that's its name.
Yes. We were just given the permission to start using Exparel, And I agree, because it hits those first 3 days, and if you can get the pain controlled through the first 3 days, then people's pain should really be minimal after that. I think that one of the important things to remember is you don't prescribe the opioids in the same amount and use the Exparel. So if you're using the Exparel, then you probably don't need to prescribe, huge piles of opioids in addition, because in that immediate postoperative time, they're not going to need them. And so you're just sending them home so that they can have them sitting in the medicine cabinet. One of the things that's important is I think that when you're looking at total cost of care, if you're adding on something really fairly expensive like Exparel, then you should probably be subtracting someplace else.
Makes sense.
And IV Tylenol also. We were initially told it was really expensive, and now we're finding out that it may be just $20 a dose. And, there is some early evidence to suggest that that's quite effective as well. So if you can hit them with the IV Tylenol and the Exparel, people really should need very minimal medication in the early postoperative time and the preemptive block, et cetera.
Loree, this is Erin. Did you guys look at all at preoperative teaching separately as a factor in postoperative pain use, or no? Or
not
narcotic
really.
use?
I mean, the nurses, when the nurses are doing their education, they quickly review the pain policy, and it depends on each physician on how comfortable they are or how much of a discussion they want to have about it. I probably tend to have more of a discussion because this is what I do.
Right.
And some people probably have no discussion at all.
Okay. And the other thing is, will some of these slides, it's hard to get back to these or some of your policies. After this is over, these aren't available necessarily online. Will somehow these be available to us afterwards?
Yeah, it sent them to Julie as separate files, and so she can send those to everybody who is interested.
Yes, and they were actually in the email that went out earlier today as a reminder. They were attached to the site, but I can email them to you, Dr. Kennedy. I'll forward it over right now.
Thank you.
But yeah, I would love to hear, what people are doing, or if people start doing this in breast or, cosmetic or any of the things.
Well, because that's why I asked, Loree, because I know with ours, in terms of both for tummy tuck, breast, and a variety of cosmetic, is that ours, it was preoperative teaching, and that we found a huge difference just in expectations from the preoperative teaching. And we just, as one of our QA studies, we didn't publish or anything, but it was just the narcotic use and request for refills based on our preoperative teaching protocols.
And basically, are you saying things like surgery hurts?
Well, yeah. Well,
I think that it sounds so insane, but to say that this actually hurts, and you're probably going to be walking bent over like your Aunt Donna for the next couple of weeks.
Yeah, and we did the same thing, that we went from 1 to 2 Q4 to 6 to 1 Q6. We said we will not, the goal is not to get rid of postoperative pain. The goal is to get you so that you can be reasonably comfortable to function with pain, because you need to walk with pain, and that just to make their expectations reasonable, and that we did the same thing looking at how many times they asked for refills, and I guess we didn't ask how many pills you had left at 3 weeks, but just if they didn't ask for a refill, we assumed that they weren't out.
Yeah.
And it was amazing, the comfort level, the time to discharge, and those type of things, 100% based on just preoperative teaching.
And that's a fascinating thing. And did it take you a huge amount of extra time?
No, none at all.
No.
Zero.
Yeah.
None.
And I imagine that, if you looked at your satisfaction, your patients were probably happier because you're addressing these things, so you obviously care about them. You're not treating them with pain. You're not treating their pain, so you don't care about them. So it's
no, because they feel that they were better told ahead what to expect.
Yeah. Yeah, And so it's been fascinating, just substituting bad care for the discussion that we all should have as just a baseline of what to expect after surgery. Yeah, you should. It would be great if you would actually publish that, and the importance of the preoperative, maybe even putting it in Plastic Surgery News.
And that could be, because we did it both, because what we started, the first one we did was in terms of getting people out of the recovery room, is because post-surgery people were like, oh, you're open till 5, I just don't want to leave. And so we did it. We started it with preoperative teaching in terms of, you will leave at 1 hour, that generally you're here for 1 hour and you need to have someone here at about an hour and blah, 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 blah. And we did that teaching, and then we expanded it to teaching in terms of post-operative narcotics, post-operative pain. And it was crazy.
Yeah.
And the post-operative satisfaction went up, narcotic use went down, our need for post-operative recovery, so our expenses went down, our recovery staff went down, all sorts of things went down, and it's all good.
Yeah, you have to publish that, please. As a QI,
I'll have to call you. I'll have to call you and get help. I don't do that side of it. I'm a simple country surgeon.
But simple country surgeon, I would be so happy to, I'd review, I could edit, I can help you with anything like that, because...
No, I'd love your help.
Yeah, that would be absolutely fabulous for you to get this information out there. It would be a godsend. So, yay. Good for you. Congratulations, and thank you on that one. Yeah, other experiences by other folks out there? Okay. Well, I'm available anytime if anybody ever has any questions. And, Erin, I look forward to working with you on this. And you know where to find me. So I really appreciate your time this evening.
Well, thank you. This has been very interesting.
Thanks, Peggy. Okay. All right. Have a good evening, everybody. Take care.
You too.
Bye. You too. Bye.